Good morning. Yay, it's a rowdy crowd. I'm APTA President Sharon Dunn, and on behalf of APTA, I want to welcome you to the 50th Annual Mary McMillan Lecture. There are many important events taking place at this year's next conference, but the McMillan Lecture is special. This lecture is, in a sense, what NEXT is all about. The opportunity to learn directly from a thought leader in physical therapy profession and to re-energize ourselves through their forward-looking perspectives. As many of you know, McMillan Lectures have a way of not only affecting you in the moment, they can also stay with you for years afterwards. I know I'm not the only person who can recall McMillan Lectures from years ago or who turns to transcripts of earlier McMillan Lectures for inspiration and to reacquaint myself with some of the most important voices in our profession. Each lecture adds more depth and richness to our shared story, and I'm sure today's presentation will be no different. As you know, delivering the McMillan Lecture is one of the highest honors APTA gives to a member. To that end, I want to take a moment here and ask all past McMillan lecturers with us today to please stand. Let's give them a round of applause. As I said, the McMillan lecturers are among the thought leaders of the physical therapy profession, and this year's lecturer is no exception. Dr. Thomas McPoil, our 50th McMillan lecturer, is a leading researcher and educator whose expertise in foot and ankle function is recognized far beyond the physical therapy profession. He is known nationally and internationally for his scholarly contributions from both scientific and clinical perspectives, including authorship or co-authorship of over 130 publications in peer-reviewed journals, serving as the editor of 2 books, and co-authorship of 6 book chapters. His work has reached beyond the profession of physical therapy by way of his past service on the editorial boards of Foot and Ankle International, the Journal of Foot and Ankle Research, and Research in Sports Medicine, and his current service on the editorial boards of the Journal of the American Podiatric Medical Association and The Foot. Like that, it was easy. Dr. McPoil is an emeritus professor of physical therapy at Regis University, Denver, Colorado, and an emeritus regents professor of physical therapy at Northern Arizona University. He's been an adjunct honorary professor in the School of Physiotherapy at the University of Queensland, Brisbane, Australia since 2001, and currently serves as a consultant to the Physical Therapy Orthotics Clinic at Denver Health Medical Center in Denver, Colorado. He's the founding president of the Foot and Ankle Special Interest Group of the Academy of Orthopedic Physical Therapy and has served as vice president of the Academy of Orthopedic Physical Therapy and as treasurer of the Journal of Orthopedic and Sports Physical Therapy. He's received numerous teaching awards, including APTA's Dorothy E. Bathke and Eleanor J. Carlin Award for Excellence in Academic Teaching, and the Academy of Orthopedic Physical Therapy's James A. Gould Excellence in Teaching Orthopedic Physical Therapy Award. And if all that wasn't enough, Dr. McPoil is also the recipient of a Fulbright Senior Scholar Award and the William J. Stickle Award for Research in Podiatric Medicine, the Academy of Orthopedic Physical Therapy Stanley Paris Distinguished Service Award, and was elected a Catherine Worthingham Fellow of APTA in 2007. Dr. McPoil's clinical practice has focused on the management of chronic orthopedic foot and ankle disorders for over the past 38 years. Today, however, he'll be focusing on a bigger issue: what we mean by excellence in our profession and how we go about achieving it. We understand this need for excellence, or we think we do, and we can point to the ways in which excellence moved our profession forward in the past and how it shaped our history. But to what degree do we recognize our individual responsibility to strive for and then maintain excellence? How do we convince others in our profession to do the same? And what insights can our collective past provide? This year's lecture will explore a very big topic indeed, but I can't imagine a better person to lead that exploration. Please join me in welcoming Dr. Thomas McPoil.
Thank you. Thank you. Please sit down. Thank you. And good morning. I'd like to begin by thanking the APTA Board of Directors and the APTA Lecture Awards Subcommittee for selecting me to present the 50th Mary McMillan Lecture. While I have always been aware of the tremendous contributions made by Mary McMillan, over the past few months, I've had the opportunity to learn so much more about her life and vision for our profession. It is such an honor to present this lecture. When Sharon called to notify me of my selection for this remarkable recognition, once the initial shock subsided, two things immediately struck me. First, how many other individuals I have known in our profession over the past 45 years who deserve this incredible recognition more than myself. And second, how ironic it would be giving this lecture just a few miles from where I started my academic career 36 years ago at the University of Illinois, Chicago. Yeah. I immediately started reading past McMillan lectures and came awestruck with the wisdom and foresight offered to our profession by these exceptional individuals. While I have always been a very pragmatic individual, trying to solve a problem or a specific question that most of the time was spawned by the patients under my care, the charge to the McMillan Award recipient is to provide a lecture related to the contributions that the recipient has made to the profession of physical therapy. While I would feel uncomfortable speaking to you for the next 45 minutes about my professional contributions, I also understand that I would not be standing in front of you today if I'd not spent the last 38 years focusing my clinical practice and scholarship in the area of the foot and ankle. That being said, I've always considered myself a clinician first, then an academic, and a researcher. As such, I'll try to focus my comments from that perspective in my lecture. As I began to reflect on the development of this lecture, the next thing that struck me was the great number of individuals who have been so influential in my professional development as a clinician, teacher, and scholar. I could easily spend the next 45 minutes recognizing all of these individuals, both in my personal and professional life, who have been such friends, mentors, and colleagues. While I realize that is not the intent of this lecture, I would like to ask for your indulgence as I recognize a few individuals. On a personal note, I must thank my mom and dad, who taught me from an early age to respect everyone, whatever their social status, level of education, or the type of work they did. They always reminded me that there was no need to boast about what you had done, just always do the very best you can. Of course, I need to thank my wife, Mary Ann, and my daughters, Meredith and Molly, for their love and support. For 43 years, Mary Ann has accepted and supported my desire to be the best clinician, teacher, and researcher I could strive to be, even at the expense of time I could be spending with her and our daughters. Most important, Mary Ann has kept me focused on what is most significant in life and helped me to maintain a humble reality about any accomplishments I have achieved. I'm also grateful to have two special sons-in-law who are watching my 5 grandchildren, so my 2 daughters could attend this event this evening. Needless to say, I have been very blessed. From a professional standpoint, there are so many mentors and colleagues who have influenced my career that I should recognize, but I would be afraid of excluding a name if I tried to acknowledge every one of them. I want to thank the Regis University School of Physical Therapy Awards Committee, Drs. Mark Cornwall, Michael Miller, Mark Rankin, and Bill Vicenzino for their time and effort in developing my nomination packet. I also need to thank two other individuals who have had a monumental impact on my development as a physical therapist and as an academic. Their first names are both Harry, and they each began their lives in Northern California. I first met Harry Berkvald in my sophomore year at Sacramento State College, ironically almost 50 years ago to the date of this lecture. This is Harry pictured with Dr. Paul Brand, the renowned orthopedic surgeon who spent the majority of his medical career developing methods for treating individuals with Hansen's disease, also known as leprosy. Harry had come to Sac State to serve as the head athletic trainer, and while I had an interest in becoming a physical therapist, I was totally focused on athletic training and not on academics. Harry took me under his wing, and over the next 2 years, helped me to understand the dedication and commitment that was required to be successful academically. I was fortunate enough to have the opportunity to work with Harry again, this time as a fellow physical therapist working at the U.S. Public Health Service Hospital in Carville, Louisiana. Again, Harry continued to mentor my professional development, encouraging me to take the time to do clinical research and to obtain my master's degree. The other Harry, who had such a profound effect on my development as an academic, was Dr. Harry Knight. Here is a picture, yes, please. Here is a picture taken in 1985 with Harry, my colleague, Dr. Dale Schuett, and me. Harry was one of the founding faculty members of the physical therapy program at the University of Illinois, Chicago, and served as chair of the program from 1979 until his retirement in 1989. Harry hired me for my first faculty position in 1983 and helped me understand what it meant to be a true academic. From his standpoint, you not only needed to be an excellent teacher, but you also had to do research and publish. Needless to say, the opportunity for me to be mentored by Harry Knight as a novice faculty member was invaluable. Finally, I'd like to thank all of the entry-level physical therapy students I've had the privilege of teaching over the past 36 years, as well as the countless number of patients who have entrusted me with their care over my 45-year-plus career. My patients and my students have been the driving force and motivation to ensure that I have kept as up-to-date as possible throughout my career on the most current and best available evidence. In thinking about my lecture, I was very impressed by the 45th McMillan lecture given by Dr. James Gordon. His lecture was titled, "If Greatness is a Goal," and he noted that the title was taken from Dr. Helen Hislop's 10th McMillan lecture. In notes from her lecture, Dr. Hislop stated, "My overriding dream is that physical therapy shall achieve greatness as a profession." While I believe that everyone in our profession desires greatness, now, 40 years after Dr. Hislop's lecture, I do have several concerns. First, who will judge if our profession has achieved greatness? It would be difficult and a bit self-serving for us as physical therapists to tell the healthcare community and society that we have achieved greatness. Second, what standard would be used to judge our greatness? And more important, before a profession can achieve greatness, I would argue that the membership of that profession must exhibit excellence. In her 7th McMillan lecture, Lucy Blair noted that Mary McMillan repeatedly stated that selling physical therapy could only be accomplished by excellency of performance and bringing comfort to the patient and improvement in the ability to function. Ms. Blair continued in her lecture to state that the early members of the APTA were indeed concerned with performance of excellence and adequate preparation for competence in practice. I have challenged every entry-level student I've had the privilege of teaching to strive for excellence throughout their career and to serve as an agent of change for our profession. While one could argue that excellence in physical therapy could be difficult to both define and judge, I would suggest that our patients who trust us with their care are an essential source of judging our worth and credibility. After all, we profess to be a patient-centered profession. As you might have noticed, I titled my lecture, "Is Excellence in the Cards?" I specifically placed the "is" before excellence to raise an element of doubt or uncertainty in our quest to achieve excellence. There are reasons for my uncertainty regarding the profession's ability to achieve excellence and ultimately greatness. Before I discuss these reasons, I would be remiss in not recognizing the remarkable accomplishments that our profession has made since I began my physical therapy career in 1973. I obtained a certificate in physical therapy after 14 months of study, 8 months of didactic coursework, and 6-month-long clinical experiences, and was able to sit for the licensure examination. I wanted to stay in the Los Angeles area to practice, but there were few employment options for new graduates. As Koning noted in her 1972 paper, more than 80% of physical therapists were employed by hospitals or nursing homes at that time. When I was finally offered a hospital-based staff position, needless to say, I was elated. But that elation soon evaporated after my first few days of working. The physical therapy department was under the direction of a physiatrist who evaluated and prescribed treatment for all patients. Every morning, I would go to the department, located in the basement of the hospital, and get my treatment orders from the physiatrist. The typical prescription for patients with neck and back conditions was ultrasound, followed by hot packs, and then 15 minutes of massage. After completing the modalities of massage, I then did Williams flexion exercises with the patient on the treatment table. I remember getting a stern lecture from the chief physical therapist when I was silly enough to attempt to do some closed chain exercises with a patient based on my athletic training experiences. He told me it was not appropriate to have a patient exercise while standing. In the afternoon, I would go to the ICU to perform postural drainage and passive range of motion on patients. Fortunately, after 10 months, I was offered a staff position in a rehabilitation unit at Children's Hospital of Los Angeles. While I was finally able to autonomously evaluate a patient, any plan of care I developed still required a physician's approval. While I think we would all agree that our profession has made tremendous advances in the last 45 years, we no longer serve as a subservient technician in the healthcare system. Our students now obtain an exceptional education and are granted a doctoral degree. We can practice in a variety of specialty areas and multiple practice environments, and we've achieved the ability to practice autonomously with patients having direct access to our services. While our accomplishments as a profession are nothing short of phenomenal, there is still room for improvement from both a clinical and academic perspectives to achieve excellence. From a clinical perspective, I'd like to provide some examples of where we can prove our level of excellence. While it has been 25 years since the concept of evidence-based practice has gained widespread recognition, there is still concern within our profession about the use of management techniques that lack quality evidence to support their utilization in the clinic. While it takes time to develop clinical-based evidence to support or refute the use of a treatment method, a key question is whether or not a treatment method should be used in the clinic before there is evidence to support the utilization. However, what about the continued acceptance of a method of clinical examination and management that was proven to have no evidence to support its use over 2 decades ago? This viewpoint was published in 2018 in the Journal of Orthopedic and Sports Physical Therapy, entitled, "If It Doesn't Work, Why Do We Still Use It? The Continuing Use of Subtalar Joint Neutral Theory in the Face of Overpowering Critical Research." The authors of this viewpoint were challenging the continued use of what I will refer to as the podiatric model, developed in the late 1960s by 3 American podiatrists, Drs. Merton Root, William Orion, and John Weed. When I first read this viewpoint, I asked myself, why 3 individuals from the United Kingdom, one of which was a podiatrist, would submit this type of editorial piece to a US physical therapy journal, the same journal that published one of the first papers in 1995 that challenged the credibility and validity of the podiatric model, including the use of subtalar joint neutral position. That paper was published by my colleague, Dr. Gary Hunt, and me. Before I continue, I would like to provide a bit of history of how physical therapists were the first to challenge the use of the podiatric model. In 1978, I accepted my second clinical assignment at the U.S. Public Health Service Hospital in Carville, Louisiana. At Carville, it was my good fortune to work with Gary Hunt, and I would further develop my interest in the foot and ankle, working with individuals diagnosed with leprosy and diabetic-related foot disorders. In 1979, Gary and I had the opportunity to work with a visiting podiatrist who had just completed a residency with Merton Root. As he shared his knowledge of the podiatric model with us, I was awestruck. For the first time in my career, I was able to actually define a normal foot type, as well as abnormal foot types that could lead to dysfunction and injury. The classification of these foot types was based entirely on the concept of subtalar joint neutral position. Regrettably, in my haste to learn the examination and management techniques, I failed to really assess the amount of evidence that justified the use of the podiatric model. As I gained more knowledge and experience with the podiatric model, I began to teach continuing education courses and co-authored a chapter on the foot and ankle for one of the first orthopedic and sports physical therapy textbooks, all based on the podiatric model. Just when I was becoming extremely confident with the model, Gary called me and said I should reread the research paper authored by Wright and colleagues. I had remembered reading the paper as it was the only research evidence referenced by Wright and colleagues in their text to justify the use of subtalar joint neutral position. After rereading the paper in greater detail, I was quite dismayed. Not only did Wright and colleagues define neutral position of the foot without any reference to subtalar joint neutral position, they only assessed the pattern of rear foot motion in 2 male subjects. Needless to say, I was very concerned about teaching the podiatric model to hundreds of practicing physical therapists and to many entry-level physical therapy students. By this time, I was a member of the faculty at Northern Arizona University and had developed a strong research collaboration with my colleague, Dr. Mark Cornwall. In 1991, we conducted 2 studies that assessed the pattern of rear foot motion that included women as well as men, and assessed various resting positions of the rear foot, including static, standing, and subtalar joint neutral position. Our results showed that Root and colleagues had misinterpreted the findings of Wright et al., and that subtalar joint neutral position had no relevance to the typical pattern of rear foot motion. In short, our results challenged the validity of the podiatric model. This work, in addition to some earlier research I had published while at the University of Illinois that challenged the podiatric model's foot alignment scheme, was not well received by certain groups of healthcare providers. In fact, our results were critically challenged by several podiatrists for various reasons. Regardless of the criticism, I realized that I would have to abandon the podiatric model and try to develop a more physical therapy-based model for the examination and management of foot and ankle disorders. We were relieved when Peronowski and Smith published a paper in 1996 that confirmed our initial findings regarding rear foot motion relative to subtalar joint neutral position. It is important to note, other physical therapy researchers had assessed the measurements used with the podiatric model and reported very poor levels of inter-rater reliability. Gary and I agreed that based on this body of research, we should write a paper that reviewed the problems with the podiatric model and presented an alternative physical therapy model. We submitted the paper, and it was published in a JOSPT special issue in Foot and Ankle in 1995. Of course, anytime you conduct research that significantly challenges an established model of practice, you're always concerned if your findings are correct. The most current research still confirms our original findings over 2 decades ago. Jarvis et al. Investigated recently the relationship between foot deformities and the kinematic compensations that were the foundations of the podiatric model. Based on their findings, they concluded that the examination protocol based on the podiatric model no longer provides a suitable basis for professional practice, and clinicians should stop using subtalar joint neutral position as part of the clinical examination and as a means of defining foot deformities associated with the podiatric model. With this background, I go back to my initial question. Why would 3 individuals from the United Kingdom submit this viewpoint to the Journal of Orthopedic and Sports Physical Therapy. I would have thought that after more than 20 years since our paper was published in JOSPT, surely the physical therapy community would have moved on and stopped using the podiatric model. In discussing this issue with several of my colleagues in academic programs, I was surprised to hear that many of our entry-level physical therapy programs still teach the podiatric model. I went online and was disappointed to see so many foot and ankle continuing education courses that would appear to still be teaching the podiatric model. Most surprising was when I went to the APTA PT Now website and under Test, searched the foot and ankle body region. The following test appeared: forefoot alignment measurement, subtalar joint neutral non-weight-bearing test, subtalar joint neutral standing test, and subtalar joint range of motion, all measurements associated with the podiatric model. I'm sure there's a reason why these tests were included on the PT Now website, and it is comforting that the poor reliability of these measurements was noted. That being said, I worry what message this sends in light of past and current best evidence, especially to our entry-level students using this website. All of this beckons the question, is it feasible to expect a clinician to modify their practice habits when best evidence overwhelmingly demands that a change is needed? Change is not easy. Antman and colleagues reported that it can take 17 years or more for clinical experts to accept changes to established time-honored management protocols based on new best evidence. In their book entitled Nudge, Thaler and Sunstein describe what is termed collective conservatism, which is the tendency of groups of individuals to stay with an established pattern even as new patterns are developed. They go on to note that once a pattern of practice has become accepted, it is likely to be continued even if there is no specific basis for it. My hope is that we will continue to stress the importance of using examination and management methods that have been validated with basic science and clinical evidence, especially at the entry level, as it is our new Doctor of Physical Therapy graduates who must serve as our profession's change agents, assuming they're getting the correct information in their educational programs. Excellence demands no less. Oh, thank you, Bob. Thank you. A letter to the editor was submitted to JOSPT that questioned why the authors of the Viewpoint had failed to include any reference to the original paper that Gary and I, or others, had published on the problems with the podiatric model more than 20 years earlier in the same journal. The authors, in their response to the letter of the editor, noted that they were aware of our paper, but because of word limits and reference restrictions, they decided to focus on more recent papers. Obviously, the authors of this Viewpoint were aware of our past research, but decided not to include a reference to our past work, even though the majority of points they reviewed in their Viewpoint were identical to the issues we discussed in our 1995 paper. Whether purposely forgetful of this reference or not, Hafeli has described this lack of awareness to acknowledge the past work of scholars in a field's history as scholarly oblivion, which can eventually lead to institutional amnesia. Hafeli writes that scholarly oblivion stems from the failure to understand that recurring themes, issues, and concerns are part of any field and discipline, and that they permeate the trends and pendulum swings of not only a field's practices, but also its research questions. She goes on to state that if we fail to cite these early studies, we are acting to erase the ideas of scholars in the field who have come before us. We ignore the history of our profession's past scholarly endeavors. As another example of this, I recently read a paper assessing the use of thermography as a screening tool for identifying pre-ulcerative lesions in diabetic feet. What struck me as I read the manuscript published in 2018 was a statement by the authors that over the last 15 years, there has been an increased interest in thermal imaging as a possible modality for the early detection of tissue damage in the feet of individuals with diabetes. I was amazed at this statement, knowing that over 40 years ago, we used thermography on a daily basis for monitoring our patients with insensate feet at Carville. The authors of this paper cited 6 references related to the use of thermography, the earliest of which was only 2004. When I reviewed all 6 of the cited references, only 2 of the 6 mentioned the paper by Goler et al., published in 1971, that was one of the first to describe the use of skin temperature measurements to identify inflammation in human skin. After reading Hafeli's paper, I thought of the danger of forgetting the wisdom and foresight of the past 49 McMillan lectures as a result of scholarly oblivion. Hopefully, our professional journals will always perform their due diligence to ensure that scholarly oblivion does not lead to institutional amnesia of the contributions of past scholars and researchers in our profession. Excellence demands no less. To introduce another example of the need to improve clinical excellence, I'd like to discuss a patient who was referred to me for consultation. A local physical therapist asked if I'd be willing to see a patient who had significant foot issues in addition to a complex medical history. He indicated she had a pair of orthoses for her feet that had been described and fitted by another physical therapist, but that the orthoses were not comfortable to wear. I asked if he could send me some non-identifying pictures by email so I could see the patient's feet. These are the images that he sent. When reviewing the images of her feet, I was most concerned with the apparent skin irritation on the plantar surface of her right foot. I saw the patient 1 week later, and her medical history was indeed very complex. She was a 58-year-old woman who was diabetic and hypertensive. 8 years ago, she had weight reduction surgery, after which she went from 290 pounds to 145 pounds. Her height was 5 feet 6 inches. She told me that recently she was hospitalized because of complications from the original surgery, and she now weighed only 120 pounds. She reported always having flat feet, but that her right foot became more painful to weight-bearing compared with the left foot, as she had gained more body weight. She noted that the right foot continued to be very painful even after the weight reduction surgery, and as a result, she decided to have surgery on her right foot to restore her medial longitudinal arch. But following surgery, unfortunately, she had multiple infections at the incision site, which led to the complete collapse of her medial arch with continued pain. She indicated trying to use several types of foot orthoses, including the current pair that were made by the physical therapist. When I asked about her current orthoses, she indicated they were quite painful to wear, and when she discussed the problem with the physical therapist, she was told to keep trying to break in the orthoses by wearing them for limited periods of time each day. When I asked about the skin irritation on her right foot, she indicated that it had started after wearing the orthoses. I was quite dismayed when I learned that I was the first of numerous healthcare providers she had seen to assess her feet with monofilaments to determine her level of protective sensation. As one might expect with her history of diabetes, she had areas of decreased sensation to a 10-gram monofilament on both the dorsal and plantar regions of both feet. What was most disappointing was to see how the foot orthoses aligned with her right foot in standing. As you can see in this image, it was easy to understand how the orthoses, made from a hard plastic material with a thin, soft top cover, would cause the soft tissue over the medial aspect of her arch region to be pinched or compressed between the shoe and the orthosis. Obviously, this was a very inappropriate device for this patient. My initial reaction was, how could this happen? Did the physical therapist not take the time to look at the fit of the orthosis to the patient's foot? I've learned through the years to never be judgmental of another clinician's work, especially in front of a patient. But to see this degree of mismanagement was disturbing to say the least. Several reasons came to mind as to what could have led to this poor level of care and lack of appropriate clinical decision-making. Carelessness on the part of this clinician, the limitation of time that can be spent with a patient as a result of low third-party payer reimbursement rates, the examination and management of the foot and the ankle being a fairly specialized area of practice, as the majority of patients and clients seeking outpatient physical therapy have spinal, shoulder, and knee complex disorders. And finally, the lack of clinical practice guidelines that can provide information on how to best manage a patient with this foot problem. Little can be done to address a clinician's carelessness, other than hoping they realize their limitations when treating a patient like this in the future. The battle for higher reimbursement rates has been an ongoing struggle for as long as I can remember, and as a profession, we need to continue the work to improve the system of payment for physical therapist services. As I noted, the foot and ankle region is a fairly specialized area of practice for the physical therapist, so why did this clinician not refer this patient to another physical therapist or healthcare provider with the knowledge and expertise to more effectively manage this patient? From my experience, referral from one physical therapist to another physical therapist is a rare occurrence. Dr. Stanley Paris, in his 37th McMillan lecture, also noted the same problem with a lack of referral from one physical therapist to another and stated, "This is what we expect from our primary care physicians, and this expectation should become a cornerstone of our clinical practice." The need for intraprofessional referral must be emphasized to a much greater degree during entry-level education. Having had the opportunity to co-author one of the first orthopedic physical therapy clinical practice guidelines for chronic plantar heel pain in 2008, I have been amazed to see the rapid development of physical therapy-based clinical practice guidelines. While the development of clinical practice guidelines is important, they cannot always guide the clinician to an appropriate clinical decision regarding the management of a patient. Case in point, a 53-year-old woman was referred to me for evaluation of her foot orthoses she had been prescribed for the management of her plantar fasciitis. Since her pain and symptoms had not improved, the patient believed another pair of foot orthoses would be the answer. She told me she was first diagnosed over a year ago and been examined and treated by 2 different physical therapists. When I asked about the treatments she had received, the plan of care she described was similar to the recommendations made in published clinical practice guidelines. Obviously, these therapists had reviewed and applied the information provided in clinical practice guidelines for the management of chronic plantar heel pain. This was especially true for the physical therapist who had treated her early in the course of her heel pain. What was concerning, as I gained more information during her history, was I was the first clinician who actually spent time taking a detailed history, and the only clinician to ask if she'd ever had a history of low back pain that radiated in either leg. She told me she had a history of radiating low back pain, but did not think that was related to her heel pain. More important, while I did not have the advantage of seeing her early in the course of her heel pain, her responses to my questions regarding the onset of symptoms, the type of pain she was sensing, and the pattern of her pain and symptoms throughout the day made me question if this woman actually had localized heel pain. After performing some neurotension tests, as well as examining her foot, I explained to the patient that she did not need another pair of foot orthoses, but that I needed to refer her to a physical therapist who specializes in the management of the spine. Clinical practice guidelines are an invaluable tool for both practicing and entry-level clinicians, but they cannot replace the need for clinical reasoning and practice knowledge. That requires experience with guided clinical mentorship, which, in my opinion, can only be achieved through residency and fellowship training. I hope you will agree with me that in considering the care experience both of these patients received as a result of their encounter with our profession, excellence was not demonstrated. After having had the opportunity to teach entry-level physical therapy students at both the undergraduate and graduate level, we cannot keep adding more information and material to an entry-level curricula in the expense of limiting our students' time in the clinic with structured clinical mentorship. Thank you. Thank you. Jane Matthews noted in her 1989 presidential address that it is far easier to add new content to a curriculum design than to delete anything. To achieve clinical excellence, we need to first consider and maybe come to the realization that it may no longer be feasible to train a generalist at the entry level. And second, consider allowing the beginning of specialization before graduation. The medical schools do it. By allowing the beginning of specialization at entry level, the transition can be more easily made to an appropriate residency or fellowship that can provide not only continued clinical experience, but structured clinical mentorship that occurs during direct patient care. By no means am I the first McMillan lecturer to advocate for physical therapy residencies and fellowships. Doctors DeLito, Jensen, and Paris all discussed the need for residencies in their McMillan lectures. After speaking with so many of my entry-level students following the completion of their clinical experiences, a common theme is the lack of extensive clinical mentorship during direct patient care, especially with those clinical experiences in the latter part of the entry-level program. No doubt, we want our entry-level students to be able to handle a full load of patients each day in the clinic. But does that come at the price of clinical mentorship? Having had the opportunity to discuss the residency and fellowship experience with many of my former students, there is little doubt that completing a residency and fellowship is critical for the development of clinical expertise and the decision-making skills. As Dr. Cornelia Kulik noted in her 18th Malley lecture, residency education is a necessary step to clinical mastery. Clinical mastery does not happen through self-study, through academic coursework, or by reading. The challenges in developing physical therapy residency and fellowship programs are numerous, including the lack of federally funded financial support, student loan debt, and salaries not commensurate with advanced clinical specialization. But as noted by Furs and colleagues, until the physical therapy profession adopts the educational progression of the professional DPT degree through residency and fellowship as the expected route to advance from entry-level novice physical therapist to highly competent specialized clinician, funding to support the development of residency and fellowship programs will not occur. I hope that our profession will continue to prioritize the development of more high-quality residency and fellowship programs. I believe our pathway to excellence demands no less. Thank you, Bob. Thank you. Next, I'd like to focus on academic excellence and start this discussion by referencing a paper authored by Dr. Steve Rose in 1982. In his paper, Dr. Rose notes that the academic way for any ranked or core faculty member is a combination of three elements: teaching, clinical practice, and research. Dr. Rose wrote that research and publication are the means by which academics in professional areas serve their science and their professions. He went on to write, academics freely engage in this process, teachers do not. Once I decided on a career in academics, I took Dr. Rose's advice to heart. If I was going to call myself an academic, besides being a good teacher, I needed to stay involved in clinical practice and have an active research agenda. In my case, the two went hand in hand, as it was my patients that helped generate many of the research questions I have attempted to answer through my scholarly endeavors. Irrespective of whether an individual is a ranked or core faculty member at either a research-focused or teaching-focused university, every faculty member should have a personal agenda for scholarship that includes publication. Unfortunately, the statistics for physical therapy faculty publication are discouraging. Hinman and Brown reported in 2017 that compared to faculty data collected by the Commission on Accreditation in Physical Therapy Education, CAPTE, in the preceding decade, the percentage of faculty with doctoral degrees and clinical specialty certifications had increased, while the level of scholarly productivity had remained stable. They also noted that 75% of accredited programs still had one or more faculty members with no record of scholarly activity. In a more recent publication, Bliss and colleagues reported that the number of core faculty members in accredited physical therapy programs possessing a PhD between 2007 and 2017 had increased by 14%, with the number of clinical specialists increasing by 46%. During the same period, the number of peer-reviewed publications decreased by 20%, while the number of professional presentations increased by 29%. As these authors note, these numbers would suggest and increased dependence on presentation abstracts to meet the faculty scholarly agenda requirements set forth by CAPTE. In his McMillan lecture, Dr. Gordon made several significant points, including the tremendous financial burden required to maintain high-quality DPT programs that produce meaningful research and scholarship, the constant challenge to find external funding to support these endeavors, and finally, that academic physical therapy programs cannot just have a teaching mission. Research and clinical practice must be an integral component of all physical therapy programs. At a teaching-focused institution, where workloads for teaching are as high as 65%, the ability to sustain an active research agenda is dependent on successful collaboration as well as strong administrative support. Both of these elements were present in my tenure at Northern Arizona University and most recently at Regis University. I was most fortunate during my 22-year tenure at Northern Arizona University to develop a strong collaboration with my colleague, Dr. Mark Cornwall, and to have the unwavering support of our department chair, Dr. Carl DeRosa. Irrespective of the challenges, and whether a faculty member is at a research-focused or teaching-focused institution, research and publication should be an expectation if one is to be considered a true academic. It's interesting to note. Oh, thank you. Yeah, thank you. Thank you. It's interesting to note that several years ago, when CAPTE established new guidelines to ensure that all core and ranked faculty were engaged in scholarship, there were numerous challenges to these guidelines, and as a result, they were weakened. My hope is that we will listen to and not ignore the wisdom of Dr. Rose, and that CAPTE will work in collaboration with the American Council of Academic Physical Therapy to ensure that all core and ranked faculty in our physical therapy programs are actively involved in scholarship and publication. Academic excellence demands no less. In closing, our profession has made tremendous advances in practice, privileges, and in the development of evidence to support the need for physical therapist intervention since the first McMillan lecture was given in 1964. As Charles Magestro noted in his 22nd McMillan lecture, we as physical therapists must never permit our profession to be jeopardized by failing to lay our hands on the patient or by not directly dealing with the patient's problem. This last point was emphasized in Sharon Dunn's presidential address last year, when she noted that the rich patient relationships that have been the hallmark of our profession cannot succumb to misaligned incentives, mounting administrative burdens, and outdated insurance plans. I hope, no, thank you. Thank you. I hope the examples I've given to enhance the quality of clinical practice and academics, in addition to the wisdom provided in the past McMillan lectures, will serve as a stimulus for excellence to be in our cards. Only then can we begin the discussion of achieving greatness. Thank you very much.